we'll move ahead with the panel discussion. And let me invite the panelists, Dr. Srikant from Andhra Pradesh, Dr. Shruti, Dr. Sharada, Dr. Jimmy, Dr. Darshit, and Dr. Shrirangwar. We had to discuss 4 abstracts. We could discuss 3 abstracts, but we'll have a panel discussion on all the 4 aspects. So can I have okay, so the first was an interesting abstract which was discussed by Kunal, and let me ask this to Sharada. Sharada, small cell lung cancer relapsed. So how do you approach a patient of small cell lung cancer who has relapsed?
Most important, I think, would be the patient's performance status, the duration from the last chemotherapy. So if duration is usually more than 6 months, then we may choose to re-challenge with immunocarbo or platinum combination. If less than 6 months, then we may have to go with the prototypic-based approaches.
Okay, this tubulinib in a phase 2 study had shown promising results. And if you look at the NCCN guidelines, and Kunal had shown that it is one of the preferred regimens in both scenarios. So with these results, would that preference change?
Sir, I think because there are so few agents available, anything new that is there, I think, deserves some mention.
Even if it is not effective?
No. If it is in this trial, it has not shown efficacy with the doxorubicin. But in a previous phase 2 study, there was it couldn't show superiority over the standard of care. So I think more trials are required to see where exactly it can fit into a disease where there are very few treatment options.
So this trial was actually planned to show that the tubulinib in combination with doxorubicin should have a superior effect over the physician choice of therapy, in which this was the classic COW regimen, which was, and the topotecan regimen which was selected. And statistically the study is negative, which means that tubulinib did not fail to achieve its primary endpoint. The overall survivals were similar, but what was interesting was the side effects were lower with tubulinib, and that was the probable reason why NCCN still has kept this as one of the options. Is it available in India? No, it's not available. Yeah. Now we move on to the second abstract which got discussed, and it was an interesting abstract, and this stands as a follow-up to the panel discussion which we did an hour and a half back of long-term outcomes with nivolumab and ipilimumab. And 2 things I wanted to talk, and Ane, you can help me here. Squamous, non-squamous, to do a repetition of what we said. Do you think there's a difference in nivolumab and ipilimumab, or it's same as opposed to other IOs?
It's similar.
So interestingly, the hazard ratios in all this pooled analysis, you could see were lower for squamous than for non-squamous, suggesting that this therapy somehow has a preference for more squamous benefits. Even if you could look at the PD-L1 less than 1%, more than 1%, though the percentages differences are different, like 3-year OS is 30%, 38% and 48%. If you look at it comparatively the hazard in the two checkmate studies, the hazard ratios are nearly the same.
Sir, I think it should be related to some smoking and squamous incidence.
Correct. So it may be related to smoking, but what this study had shown was, even if it is squamous and even if its PD-L1 is less than 1%, it still benefits. Yeah, sure, Sandeep.
Can you say, there is a relation between squamous and smoking, but in this four study, more of patients are from non-squamous.
Correct.
And patients are smokers.
Correct. What you are saying is correct. The second logical point is also, if these smokers, they tend to have a high PD-L1 score. So that logic that it is active even in patients with low PD-L1 score won't hold true against that argument. With that, we'll go to the next, and I tend to spend a few minutes more on this aspect. So today, if you have a untreated resectable, stage 2A and 3B. So first of all, and this question will go to all panelists, and this time we can start from Samir. 3B and 2. In your institute, do you go for resection upfront or you give near-adjuvant chemotherapy only?
Near-adjuvant.
Near-adjuvant.
So So if not in the mediastinal group of lymph nodes, then I would prefer the surgery first and then adjuvant.
Okay, so you would prefer surgery first and then going for adjuvant therapy. And
So majority of them will go for upfront surgery.
majority of them, even if there are mediastinal lymph nodes.
Mediastinal lymph node, then they may refer for.
So 3B would stand for people who will N2, okay, or it is T4. So in that subgroup, would you institute practice upfront surgery or it would be neoadjuvant therapy?
Neoadjuvant therapy.
Okay, Sharada, same with you? Yeah. So normally when it is 3B, it is most of the time because of N2, the preference would be to give neoadjuvant therapy and then assess the patient for surgery. Can this patient be taken for chemoradiation? They are resectable. Can this patient be taken for chemoradiation? We are focusing on 3B only at present. Sharda, we have sessions after this on which we will be talking about chemoradiation consultation with you. That time I hope the moderator take this question. But 3B, would you say that, let's say he goes to Chakor in Pune and Chakor says, okay, this 3B N2, you go ahead with chemoradiation. After chemoradiation, I want to give you durvalumab. Is that right or is that wrong?
It's an option.
Correct. That remains an option. So 3B N2 is even if it's resectable, it's a space in which both chemoradiation also is there. You have surgery also as a local therapy which remains an option. The question is, would you want, and let me put it that way, so would you today in a 3B who is a resectable want a PDL1 score to be done to take a decision, or irrespective of the PDL1 score you would say no, my choice would be to give chemo and neoadjuvant immunotherapy?
So as per the current data, there is no need to do a PDL1. You can go directly with the neoadjuvant chemo with nivolumab.
Okay. Would you send the patients, it's a 3B and let's stick to 3B and N2 has come, would you send the patients mutation analysis? Let's for this discussion take that the patient turns out to be mutation positive. And let Annie take that question. 3B N2, resectable, patient turns out to be mutation positive, patient turns out to be ALK positive. Now what do you want to do?
In mutation positive patient, the immunotherapy is less effective. So we would tailor according to adjuvant TKIs.
So no, the question is you're sitting in a multidisciplinary tumor board. Now your surgeon is sitting next to you, he's saying, okay, I can upfront resect it, or do you want to give neoadjuvant chemotherapy, then resect it, then put him on an adjuvant alectinib? What do you want to do?
Then upfront resect, and I would like to put them, if it is resectable, I don't want to miss the chance, upfront resect and put them on TKI.
Okay, Sharda, would you agree with that? Do we have any surgeon in the audience? I think Navneet sir, what would you have done? 3B N2 patients, we were planning neoadjuvant immunotherapy, we sent EGFR, ALK came positive.
So I'm not a surgeon, so I'm very much in your community. So the question is, it is an N2 disease,
N2,
right?
N2, yeah.
And it is still potentially resectable.
Yes.
So it is unlikely that you subject the patient to neoadjuvant therapy and it will become unresectable. So obviously if it is ALK positive, there is very little benefit of doing chemo immuno. You would do neoadjuvant chemo, get a surgical resection and then give adjuvant ALK inhibitor. We have ample evidence, I mean we have that strong evidence from the arena trial.
Yeah, that would be so. Yeah.
It's like bottom acceptable and positive. I will give a few bits of ALK inhibitor then.
Okay, so
you don't have data for that.
correct. So you don't have at present data for that. There is a study which is actually going on. But I would agree with what Dr. Navneet Singh said that it's an N2. You would want that neoadjuvant chemo to go. Then you won't add an immunotherapy. You would do a surgery and then you would probably put the patient on a adjuvant therapy. So let's come to this situation. So irrespective of PDL1, you want to do it. So what if your surgeon says that if you have given chemoimmunotherapy, the chances of having surgical complications are high?
No. The surgical section is quite high.
So So that's correct. The surgical resections were quite high. There were concerns which were raised by quite a few of my previous institute colleagues also, that when we operate patients after immunotherapy, we might have bad amount of fibrosis, and these concerns were raised. But all the studies, whether it could be for nivolumab, whether it is for pembrolizumab, perioperative, all have clearly shown that there are no increased rate of surgical complication post giving neoadjuvant immunotherapy. So at present, this argument does not seem to be validated by the data which we have. It might be a learning curve, which might be there in some institutes if they are not operated patients after immunotherapy, but at present the data is very clear, and you could see the last time the surgical related AEs are very similar between both of this. Now, my question is, we gave chemo and immunotherapy. We got an excellent PAT-CR, 25% versus 4.7. The major pathological response rates were also 35 versus 8. Why was there no change in definitive surgical rates or RGO resection rates? You could see the third point, definitive surgical rates were 78, 77, 89, 90. So like for example, take you to corollary of breast cancer, where we used to give locally advanced breast cancer, more the response, we used to see more amount of resections. Why has this not happened in this study?
These were all resectable patients.
Correct, these were all resectable patients. So probably if we had some borderline resectable cases, we would have seen this all were actually potentially resectable patients which were taken in this study, and that's the reason why this is one of the another argument which comes into play from our surgical colleagues, that there was no increase in R0 resections. These all were resectable patients. And interestingly, you could see that there is no difference in resection rates between the two arms. And this is an interesting, and I had hoped this abstract was presented. Clonal KEAP1 mutations. So, Samir, we'll start from your side. So, today when you ask for immunotherapy for a patient in lung cancer, do you get a CGP done? Because you won't get KEAP1, RAS and STK11 in the lung panel. Most of the small lung panels are not there. Would you get this done?
So cost is not an issue.
So the patient is going to afford immunotherapy. So logically, cost should not be an issue.
So I won't advise.
Okay?
So definitely we would like to advise the inclusion of these mutations in the panel. It will give the better idea to which treatment we should go further forward.
So let me bring Dr. Navdeep Singh sir here again. Sir, so if you see a patient who is for immunotherapy, let's say PD-L1 score is high, and you get a clonal KEAP1 mutation along with the KRAS and STK11, all three are mutated, are you today going to say that, okay, there is data that this may not do so well with immunotherapy, so let me decline or say no to immunotherapy? What would be your approach in your practice?
Can you just repeat the question? PD-L1 is high.
PD-L1 is high, let's say it's 90%, sir.
So, the presence of these coexistent mutations may portray that patients may not do well to monoimmunotherapy. And the temptation here would be to give the combination of chemo-immuno. Remember, a high PD-L1 does not say that you don't do chemo-immuno, it just says that if needed, you could do with immuno alone, but wherever the situation demands, you could still do the chemo-immuno. So yes, this would be a case in which one would be tempted to consider chemo-immuno rather than immuno alone, even with a high PD-L1.
Yes. I think Kumar sir, what would be your... Let's make this situation a bit more controversial. Let's say that PD-L1 has come 20% and CGP was done, and you have KEAP1 mutation, STK11 mutation and KRAS mutation there, and the patient is all affording. What would be your approach to this patient?
So, data is all over the place.
Yeah.
So today, do it. It gives you some hint, but treatment doesn't change.
Yeah.
Treatment remains. It's a bit like P53 and EGFR.
Yeah.
Again, we analyze our own data. We reviewed it, that part. So there is an issue regarding not only KEAP1, you have MDM, you have STK. So there are many of them. There are some panels of combination, and all those looks very good in retrospective data. the moment they go for prospective validation, looks like again they start faltering. So as on date, learn it, but having said that, they're not necessary.
So the message is
Discussion would be here whether to use a regimen like 9LA where you give only 2 cycles of chemo, or whether use pembro plus chemo where chemo will be there continuously till the disease progresses.
So I'll tell you, the bottom line remains, when you are in doubt, you combine.
Yeah.
And that's the key. So, as much you may go on having, we may have a discussion, does the PD-L1 alone decides everything? Let's take it, PD-L1 around 51% and non-smoker, female. Then you start thinking, oh, should I combine or not? So that for me, bottom line remains, you have many criteria you put in. And I take the point that whenever in doubt, you do combine. But is this the basis of doing it, it's alone basis of doing it? It does create a doubt in your mind, then you can.
So what Sir and Dr. Navneet hinted us is there is some data to suggest that there would be differential efficacy, but at present we are not modifying that treatment. Definitely we may not want to go with the mono immunotherapy. Any last comments from the panel, because this was the last abstract I had.
So just a comment about the previous trial. Compared to the standard of care trial, the initial NHM published article where nivolumab was given as only as the neoadjuvant strategy, this trial has given adjuvant nivolumab also. So is it actually necessary, because outcomes were almost similar. Long-term outcomes are not available for both.
Yeah.
So what would your approach be now that this is out and that is a published paper?
So I tended to follow that previous paper. Okay, and the only whole idea of why I was following that paper was there was no adjuvant. So my counseling used to be that okay, we take 3 neoadjuvant immunotherapy and this is the outcome. And I would stick to that unless the trial shows that the adjuvant immuno adds something to about that. We'll take views from Dr. Navneet and Dr. Kumar also from this.
So only problem, I agree, I also do the same thing. Only problem is the data 867, the Pembro data which we have. And that's the first one for OS. And that is what, and that's perioperative. I know we as a clinician and a patient wants preoperative. Perioperative we don't want. In 816 also what happened, they did one subgroup analysis for, it was allowed that if you want to give perioperative you may continue. There's some 11% or 12% patients they gave it. And there is some hint there. Oh, those are all hints. The problem is that this Pembro perioperative, that's a problem. That what creates a doubt in our mind. But as Vijay said, we also don't. We also, at 3 to 4 remains, usually it's 3, there are people who have given 4 also. After that we don't give it, but again, there can be a debate. You give it, and then you have you don't have a major pathological response. But that debate will continue. But pragmatically, 3 to 4.
So one follow-up question to that, these patients were resectable. Let's say that the patients were like Nadim 2, which were like borderline resectable. Nadim 2 did give head. So in those cases, would you want to give adjuvant for 6 months?
In fact, that was one of the reasons for 816. 816 was based on Nadim 1 and Nadim 2.
Yeah.
Nadim 1 was 1 year,
Yeah.
Nadim 6 was 6 months. So someone said, hey, why did you do that 3 to 4 cycles? But they allowed perioperative, and I do agree. Nadim 2 was end-to disease, and where we do not necessarily everyone wants to operate. After 816, also people did feel that if you are end-to disease, give something more than 3. That was, but again, it was evidence based. I leave it. I say no. I'm okay with if Vijay says I'm going to give 3. I won't be debating. I say that's fairly fine, and we do the same. We have a problem regarding sometimes so-called early palliative we have defined. Excellent responses there. Now, 2 patients got surgery done. And now there is separate debate happening in the JC. Say, hey, if you do surgery, why you want to give further treatment? That's a separate debate here. But here, I think so. What Vijay is saying that end-to disease, which is resectable, and then what?
Nothing really different. I mean, if there are 4 or 5 criteria for doing surgical resection, despite not being a surgeon, absence of extrathoracic metastasis, absence of intrathoracic metastasis, primary being resectable, absence of N3 disease, and N2 disease not being bulky or multistation. When you started using neoadjuvant chemoimmuno, this definition of resectability and unresectability starts to get blurred. And what previously used to be thought as unresectable may become resectable. So, but if you are able to give neoadjuvant chemoimmuno, that typically is 3 to 4 cycles, and the surgeon says I can get an arsenal resection, I think that is worth it. The debate about continuing immunotherapy post-operative is going to depend upon several factors, including the pathological stage, absence or presence of poor prognostic factors like STAS, lymphovascular invasion, perineural invasion, etc. The molecular profiling of the tumor, presence or absence of EGFR and ALK, and the PD-L1 status, and in times to come, the presence or absence of MRD.
I think that time is up. So thank you panel and thank you audience for the discussion. Thank you.